Welcome to this episode of the NBCOT Exam Prep Course Review, OT for Cerebral Palsy. CP focuses on the developmental skills necessary for the performance of occupations such as ADLs. So there is a focus on facilitating and promoting independence for the patient. This video will review cerebral palsy for the NBCOT exam. If you are only watching this from YouTube, be sure to enroll in the free course for study guides and quizzes for topics such as this one, CP, after watching the videos. The link will be in the description. I'm Jeff, the OT dude, and let's get functional. Cerebral palsy is a non-progressive disorder of the CNS etiology that is sometimes referred to as static encephalopathy. CP is considered to be a neurological condition that affects posture, motor function and movement, as well as cognition. It is often associated with epilepsy, language and speech abnormalities, sensory issues such as vision, and psychosocial deficits. Pathophysiologically, in CP, there is a lesion in the developing brain, and as the child is developing, CP can have a large impact on all aspects of early life as well as throughout their lifetime. There are considered to be two major types of CP, congenital and acquired. Congenital can occur anytime from prematurity to birth. One suspected cause is CVA during this time, as well as other traumatic events such as hemorrhages, even environmental toxin exposure associated to be with causing congenital CP. Risk factors also include low birth weight, premature birth, multiple birth history, some infertility treatments, and medical complications. Acquired CP can be a result of injury or infection and is often thought to be preventable. Examples include poor blood flow and hypoxia, CNS infections, car accidents, falls, and child abuse. Let's review the symptoms of CP. These can be summarized based on the categories of 1. Movement and coordination, 2. Speech, and 3. Development. With movement, people with CP often experience spasticity, rigidity, ataxia, tremors, or slow writhing movements. Be sure you're familiar with these terminologies that I will mention in the video for CP. Functionally, people with CP may favor one side of the body, such as when reaching. They may experience difficulty with ambulation and have altered gait patterns, such as toe walking, a crouched gait, scissored gait, widened gait, or an asymmetric gait. They may also have difficulty with fine motor skills for daily activities and ADLs or school. With speech, there may be delays, dysarthria, dysphagia, and excessive drooling. Developmentally, there may be delays in reaching motor milestones, learning difficulties, intellectual difficulties, and with growth, such as having a smaller physical size. But keep in mind that potential cognitive impairments are not all nature, as in nature versus nurture, and they can be also influenced by environmental influences during one's development. Other neurological problems impact the senses, such as hearing, vision, touch, and pain. For example, there may be nystagmus and strabismus, which is the misalignment of the eye or being cross-eyed. There may be bowel and bladder issues, and even seizures. Last, there may be psychosocial and behavioral problems. And it's important to remember that symptoms don't worsen with age, but due to actually the changes or complications that may occur, such as due to contractures. So certain symptoms do worsen, but it's not due to the actual disease process, but instead something else, if that makes sense. Now let's review some terminology associated with CP. Involvement of CP may be hemiplegia, quadriplegia, aka tetraplegia, and diplegia. You're all familiar with the hemi and the quad. Diplegia is kind of like quadriplegia, but with mild upper extremity involvement, and more involvement in the lower extremities. Spasticity is an increase in tone. Well, what's rigidity then? Well, one difference is that pathophysiologically, where spasticity is caused originating in one location of the CNS, rigidity is somewhere else. On the other end of the spectrum, you get flasticity, which is the opposite and low tone. People with CP usually progress from flasticity to spasticity. Remember that even though that they may progress in symptoms due to other factors, the diagnosis itself and the disease process itself does not progress. Just wanted to try from that point. Athetosis is then the fluctuation of tone from low tone to normal tone. Chorioathestosis is another type of fluctuation of tone from low tone to high tone. And notice the difference in the tones between athestosis and chorioathestosis. Dyskinesia means involuntary or uncontrollable movements. You can, by the way, quiz yourself with the NBCOT exam prep quiz for the topic in this course, so be sure to check out the link in the description to enroll and check it out for free. And it's also important to keep in mind that there is a broad range too of severities from mild severity to very severe, and that each individual is different. I mentioned that there are two broad types of CP, congenital and acquired. Another classification of CP is Spastic CP, Dyskinetic CP, Ataxic CP, and mixed type CP. As you could guess, with Spastic CP, someone would have increased muscle tone, resulting in the difficulty of movements and with function. Spastic CP usually describes the terms too, hemi, quad, and diplegia types of CP. With spastic diplegia, for example, what do you think is more affected, the arms or the legs? Answer is that the legs are mainly affected. With dyskinetic CP, some examples include athetoid, chorioathetoid, and dystonic CP. Athetoid means slow, writhing, involuntary movements, right? So they would have uncontrollable movement that may be slow, or it may be fast, but jerky as well. It can also affect the face and tongue as well, being besides the extremities. Overall, dyskinetic CP results in varying tone. Ataxic CP results in problems with balance and coordination. Ataxia, such as with walking. Ataxia, the term, is characterized by a wide, staggering, unsteady gait that causes someone to walk very quickly to maintain their balance. It can also affect more fine motor skills too, such as with writing, as you can imagine, due to the sudden quick movements instead of controlled ones or when reaching for something. Last, the mixed type of CP results in a combination of symptoms in more than one type of CP in the categories that we mentioned earlier. For example, a common type of mixed CP is spastic dyskinetic CP. Overall, the prevalence is made up of approximately 70 to 80% spastic type, 10 to 20% athetoid dyskinetic, 5 to 10 ataxic, and mixed the rest. And the neuroanatomy, just because I am interested in this topic a lot, is that spastic CP has motor cortex involvement, athetoid dyskinetic has basal ganglia involvement, and ataxia has or is originated from cerebellum involvement. And knowing this actually helps to explain the cause of muscle tone and the movements because of the locations in the brain and their associated functions, such as the cerebellum for ataxia. And for parents, they may notice that some early signs, such as around 6 months of age, include babies feeling more stiff, floppy, or they may get stiff when picked up. With movements, the baby may not roll over or may not bring their arms to their body or have difficulty with reaching. In older babies, such as 10 months, they may have atypical crawling patterns or scooting around. And even though I mentioned that CP is non-progressive, I really wanted to re-drive home the point that changes that do occur are due to other factors, such as the child's growth and growth stages in their development, or occupational participation or lack thereof, and their life role changes even, to name a few. The treatment team for CP includes physicians, specialists such as a neurologist, PT, OT, speech-language pathologists, educational psychologist, nurse, and a social worker or case manager. Overall, early intervention and school-age services can be beneficial for the child, such as through the IDEA. IDEA Part B applies for school-age children from 3 to 21 years, and IDEA Part C for earlier intervention from birth to 36 months. And it's kind of reverse. You would think that B is earlier. Maybe they added on afterwards after they figured out that this particular younger group needed more interventions or because they weren't getting any. I don't know. And medical management may involve things such as pharmacological, surgical, positioning, orthotics such as AFOs for spasticity and to prevent contractures, and much, much more, as we will see later in the research. You should know that an example of some medications for spasticity are baclofen and Valium. Botox is also another widely used one via injection into the spastic muscles rather than oral intake of the Valium and baclofen. You could also consider this to be one of the team goals, basically, for musculoskeletal management. However, as mentioned with the IDEA, early intervention, school, and a wide lens approach to this condition as it is lifelong, from diagnosis to old age, in the different stages of life is important. CP also just doesn't affect children and go away all of a sudden, right? It lasts until throughout one's lifetime. With outcome measures, the ones to focus on are the top-down ones: COPM, goal attainment scaling, activity card score, or pediatric version anyways, sensory profile to name a few. With spasticity, the modified Ashworth scale. Measures I have seen also being used in the literature include the WeFIM, PD, Child Health Questionnaire, CHQ, also some hand function measures in the research, such as the Abil Hand Kids, Erdhart Developmental Prehension Assessment, Box and Blocks. Other measures include ones that you've learned about as well, such as the Peabody Developmental Motor Scale, the Bailey, and the BOT, BOT. Now let's review some OT intervention. It is mostly based on the symptoms and components of the outcome measures that we will see. However, not always the case for the best evidence-based practice. The focus, especially for early intervention, is, for example, to help the child gain control over their symptoms, such as through muscle and motor control. Positioning is also important to minimize abnormal tone, but you will see how later that the evidence is mixed contrary to what you would think intuitively anyways. Also, from a theoretical standpoint, traditional approaches such as NDT and sensory integration and the systematic reviews have been inconclusive regarding their efficacy. More on this later. A large part is educating the caregivers about how to handle the client and for their participation in ADLs, school, socialization, and play. If you do decide to use certain approaches, be sure that they are statistically sound, sensitive outcome measures that are sensitive enough to detect and attribute changes to your variables of intervention. Some general bottom-up approaches that I have learned about for CP include interventions for motor, range of motion, tone, coordination, and strengthening to address barriers in tone, motor planning, and motor control. We reviewed how orthotics and splints may be used to help maintain range of motion, as well as adaptive equipment and assistive technology can be used for seating and positioning. Examples of certain splints, such as that for the upper extremity, include the resting hand or knight splints to maintain range of motion. Also, soft splints and dynamic splints are also used. And at this point, I like to be more provocative and differentiate what you and what I actually even learned in the textbook and maybe in school compared to the research and evidence-based practice. Because I was looking at my lectures, OT textbooks and stuff while reviewing that material before I made this video, and I really couldn't find many interventions for CP compared to other conditions such as stroke or something in the exact same sources of material even. And the ones that I did find were more medically focused, like medically team management for CP, like medications or injections. And I'm not saying that what you learned in school is necessarily wrong, but it may conflict with the latest EBP. I'm just presenting the evidence. So hear me out because this is important to keep in mind for CP because ultimately it's not about us. I would argue that we got into OT to do it for our clients. So the outcomes and the well-being of our clients and their families is of the utmost importance, right? So in a systematic review of the interventions for children with CP published in 2013, they found 30 to 40% of interventions to have no evidence base and another alarming 20% of interventions to be either ineffective, unnecessary, or even harmful. So there is a dangerous gap between research and practice for CP. We all want to help as healthcare providers, but unfortunately, we may not have been, especially when it comes to interventions for CP. So this is why I do what I do for OTDUDE and the content that I make, because although I am an OT, I don't technically have skin in the game when it comes to certain interventions or approaches or whatever. And it's not about me, but my clients in my community and improving healthcare outcomes. So mentioning these things and presenting the latest research and getting the message across is a big deal to me. And I get passionate about it because I'm kind of tired of the old and there needs to be change, especially in healthcare and mental health for Americans. So you should be primarily top-down and client or family-centered and consider personal factors, environmental factors, and other ones that are outlined in the OTPF for best practice. However, I'll mention some of the bottom up because you don't want to do this as much as possible because it would be addressing specific underlying impairments such as tone. But what's better as an approach, top down or bottom up, right? A top-down approach would be able to consider how an OT can maximize a client's participation in personal goals as independently as possible within their environment. If you don't remember anything from this video, this is the statement or the big takeaway for CP that I want you to remember, not just for the NBCOT exam, but when it comes to these types of conditions and how it can affect basically a life. So the systematic review summarized the following research. Alternative and augmentative communication technologies had low evidence and weak strength for recommendation in OT practice. Animal-assisted therapy was also the same, including hippotherapy. Assistive technologies and supports such as walking frames and wheelchairs were also to have low, inconclusive, weak evidence. Kind of provocative, isn't it? So was baclofen for spasticity. Behavior therapy was low for the quality of evidence as well as the strength of recommendation was weak for behavioral types of therapies. Bimanual training, so both extremities through repetition, had high qualities of evidence and a strong recommendation for practice. Biofeedback we often hear as good, I think, but in case of CP, evidence was low and weak. Botox injections was found to be moderate to high, and some studies even had strong recommendations for its use in reducing spasticity, but not really for its intended use to help with pain. Casting was low, but overall weak for recommendation as well. Psychosocially, CBT, often we see that it works for a lot of other conditions. In the research they found in this systematic review, inconclusive for CP. CIMT, constraint-induced movement therapy, had a moderate quality and a strong recommendation for practice. E-stim was found to be inconclusive though. Fitness training was found to have moderate evidence with strong recommendation for practice. Now here's a good one. Goal-directed and functional training was strongest for hand function and self-care. Also, home programs through goal-based tasks led by the parent and guided by the therapist in the home environment was found to have moderate evidence and strong recommendation. Hydrotherapy was low and weak. NDT had a strong recommendation for use, but the quality of the evidence was low. Maybe it's been outdated. I don't know. A combination approach of improved hand use with CIMT and goal-directed training, all these factors and strength training and functional enhancements was found to be effective with high evidence and strong recommendation for practice. So that's probably the one to go to. Play therapy was low and weak. I know I will probably contradict myself here, but seating and positioning with assistive technologies were found to be low and weak with insufficient evidence. Sensory integration, i.e. hammock swinging. So it had low quality of evidence, but a high recommendation. So take that for what you will. The panel that commented on these types of studies found overall SI to be ineffective for CP. Sensory processing was also found to be weak. Resistive training to promote like the progression of more challenging exercises for like muscle strengthening was effective, but only in the short term. Manual stretching, say for contraction prevention, was found to be moderate and a weak recommendation. And an interesting one I saw was whole body vibration, such as with assistive technologies to transmit like low frequency vibrations to certain contact points in areas or surfaces on the body, such as the feet while standing or the buttocks while sitting, for hopes of improving one's strength and gait, had low quality of evidence. So maybe watch out for those types of interventions, especially if you're a consumer looking into this type of intervention or product for this intended purpose. In my research, I found other interventions to be used, such as direct training of skills, such as with dressing. And you'll notice that in your NBCOT study guides, even like the AOTA PDFs, that they don't mention certain approaches, such as NDT or SI. Okay, good so far, but they also propose other contradicting approaches too, such as adaptive equipment, assistive technologies, which we just have seen that the research does not support for CP. Interesting, isn't it? So this is kind of a lesson that even some textbooks or study guides aren't presenting the latest and most beneficial EBP to our clients. It kind of blows my mind. But anyways, as much as I like to tell you that OT is awesome and works for this and that and for CP and this intervention will probably work for it, some systematic reviews just have found mixed findings on the efficacy of OT practice for children such as CP. And as CP can affect not only the patient, but caregivers and the family, the OT should also provide support to help them manage behaviors and their own stressors to prevent burnout. I think you can't argue about that in the research. In summary, CP is a non-progressive neurological condition that may have a variety of symptoms that affect development and function, not only during childhood, but for an individual's entire lifetime. So it is important for the OT to be aware of this and how it may affect their clients and not make any assumptions based on their diagnosis and what to do with interventions, like check a box, okay, we'll do this because they have that. But to remember that each individual is unique and they have their own strengths and their barriers to participation in their goals for whatever occupations it is. And while intuitively many OT approaches and theoretical frameworks have been seen to be beneficial, at least historically, you should always have flexibility in your thinking and practice and be willing to look at newer approaches or better approaches that are evidence-based with sensitive enough evidence and outcome measures for the OT to practice with. And because it's not an exact science compared to like chemistry. So this is how EVP will evolve, I think, with practices, with medicine, with OT. So I hope this helps. If you found this video helpful, I know it may have kind of confused you guys, but I wanted to kind of stir some thinking and some critical thinking and just not to be so rigid in your thinking, because that's not how we should practice as practitioners in healthcare. So if you found this video helpful, be sure to give it a thumbs up, share it with your study groups, and also consider supporting the channel, such as through becoming a Patreon member or donating or through any other means to help support the channel. Thanks for watching. I'm Jeff, the OT Dude. Good luck studying and have a great day.